Welcome to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Grant Garcia. Obviously, Dr. Garcia is paying hefty money for his chat GBT background. His mind is looking a little, it stabs me in the head there. I mean, I'm
Yeah,
really
I don't know what you did. I'm gonna have to work on some of your typing skills. I don't know what's going on over there,
yeah,
but this is okay.
yeah, I definitely do. Listen, we're really excited about our guest today. But before we get to our guest, let's handle a little housekeeping there. We love Mike B and the recovery shop, but who can talk about the recovery shop better than you can? Take it away, buddy.
Yeah, so again, big thanks to our sponsors. For any surgeons out there, this has really been nice for me because the patients always ask what extra. We're going to get into extra you can do during the surgery, but how about after the surgery, right? So after the surgery, the ability to have sort of advanced rehab stuff, nutrition, things like that, it's all available here. And the nice thing is each surgeon can have a customized page for their patients. So it really is nice. It's sort of like an a la carte option. So my patients in Seattle, they love it. They're always asking questions on what else they can do. We're gonna bring up one of the topics they talk about all the time, but before we jump to that, this recovery shop thing is awesome. So look into it.
Yeah, and maybe they can find a way to fix my background since they are able to fix everything else. So I don't think that's what they mean by the recovery shop, but shout out to Mike B and everyone else. We really appreciate them. Listen, we don't care about the doctor that's coming on because he is the pride of Chesapeake, West Virginia, right? He is the pride of West Virginia. Let's bring on Dr. Chad Lavender. Dr. Lavender, listen, how big is that town? That town is less than what, 1,500 people, 1,200 people? I mean, you must be the talk of the town, not only in your town, but across the United States, across the globe. But what's the feedback just getting, from the folks in your town?
Oh, I think so. I practiced maybe 30 minutes from where I grew up, and
Beautiful.
in a slightly larger town, not much, but that's part of the beauty of being here where I grew up is I get to treat basically my extended. Everybody here is related some way to me, right? So many people I've known all my life are their kids, and I think so that's why I've chose to stay in this area. Is very fulfilling.
So again, to introduce him, Chad Lavender is Marshall Orthopedic surgeon. The big reason, obviously, he's here for many reasons we'll get to in a second, but you guys have all heard the thing we talked about in numerous episodes, even before we had our video episodes, the fertilized ACL. I will tell you that pretty much weekly to every other week, I get someone asking about this. I hear it at conferences. I work with Arthrex too, just like Chad does. So I get people talking about this as well. This is a very hot topic. And we'll get into in a second why it's so important. And then obviously we got some other twists and turns here. So we're going to talk about the nanoscope. We've heard about it with, we talked with Chubb when they talked about how his recovery was better because of the nanoscope surgery he had done. So we'll pop in and ask Dr. Lavender, who's sort of a specialist at this. And then obviously he's a football player. So he can tell us about his experience with football players and how that coalesced. And then just classic board certified. So this is awesome. So thank you so much, Chad, for coming on. I think everyone's really excited. I want to, kind of hear more about your background, maybe kind of, I know you told briefly, but sort of how did you get to this point? And then we can jump into some of the topics.
Yeah. So we talked a very small town in West Virginia, very blessed to have a great family support and community support and coaches, and ended up walking on at WVU and played backup long snapper there. And then went to medical school at WVU and then attended Marshall, which is where I currently work for residency. And then I spent a year specializing in sports medicine in Richmond at Orthopedic Research of Virginia.
So. Nice.
Yeah, Dr. Lavender, I know what you do is really complicated. And, as Dr. Garcia mentioned, we've talked about this procedure in numerous shows. So we're really glad that you're here. But is there anything harder than walking on to West Virginia and trying to get on the team as a long snapper and not only getting on for that season, but pretty much the seasons that came after that? How difficult was it to just be in that situation and be blessed to be a part of that university?
Oh, it was a dream of mine. To be able to live your dream is something very few people get to do. And I had a dream to do that, and then be an orthopedic surgeon. And I'll tell you that I can remember vividly Coach Nealon. He looked at us our first team meeting, and he said, the hardest thing that you'll ever do in life is maintain on this football team for 4 to 5 years, because it takes consistent work, much like medical school. I mean, it's very, very similar to medical school. I think it prepared me very well for those years in residency, because it was grueling, not just physically, but also mentally, So then you get to medical school and it's mostly mental, right? It's not as much physical, but I think it was the 5 a.m. workouts and the things they put you through that really helped the mental toughness, So yeah, it was really hard. I mean, I was 5'11", maybe. I'm 5'10" now. I was listed as 6 foot. So
I love it. Well, you can see, Will, though, again, this is the reason, and Chad can remember this, but the athlete checkbox is huge for orthopedics, right? Mm-hmm. There's a reason for that, right? They just don't give up. I did 4 years. I was not football, but swimming. It's the commitment, right? Like the 1 year athlete, like that's great, right? That you can do that. That's easy to do. That's hard to do in some cases, but the 4 years, what you did, that shows dedication. And it's going to jump right into the next topic, right? Because what you did for 4 years, now you got to basically do something, and you want to do something that's different than what people have done before, right? Like this fertilized ACL, and we can get into it in a second. Like this is bucking the norm, Will. Like this is not like we've talked about like ACL repairs. Like it's the same sort of situation. Like everyone's against you, right? They're really against you, and you have to like kind of be like, am I going to take this on, right? I mean, Chad, you have the weight of 10,000 or more orthopedic surgeons that are like, no, this is the way we've done it for years and years and years. I mean, what was even that started making you think that you could take this on?
So I think I would go back a second and say where we're practicing, okay, which is in small town West Virginia. And I wasn't a team doctor for X NFL team or Division I Power 5 program. And the patients that came to me trusted me. And, and we would have informed consent. And I would say, look, I think this is going to help you. This is what we're planning. This is research. And they trusted me. And the patients that are in the trial that you're going to mention, many of those are from this area. And they had full trust in what we were doing, So it's interesting. In the very, very early days, we weren't under the microscope like you're discussing. And then really quickly, it turned into, okay, I'm on a stage and there's 1,000 orthopedic surgeons out here and they're wanting to throw tomatoes at me. I mean, I can remember it. I can remember the first time that I presented just the technique. Okay. Just the technique. And I'm outside and I'm nervous. And, because like you said, it's one thing to present in front of people about ACLs and hamstrings versus quad tendons. It's another to present a completely mind changing, procedure. And so I remember the guy outside, one of the reps, he came up to me and he said, and he was telling me this story about a mountain biker or an X Games type guy. And he was like, and he said, the worst thing that can happen is I could die, and I was like, why are you telling me that when I'm getting ready to go on stage, man? Come on. And so that kind of lightened my mood. I went up there. I think it's all about putting things in perspective and really, I would, and I've talked to other innovators since in the last 8 years. And, I would say that there's really 3 different phases. There's the very difficult early phase where everyone is against the idea. They really don't want to believe or don't have open minds. Then they start asking questions and they're inquisitive. Then you get to the phase where people start to adopt the procedure and ask about the procedure and want to learn about the procedure. We really got to the 3rd phase fairly quickly. And I would say, I think our first publication on the procedure was around 2017, 2018. And, you know, there's two different parts of the procedure we'll talk about again, but I would say that the internal brace was more controversial than even the biologic portion.
Interesting. It's funny because Will and I think about that, and that's Will's favorite topic. So be careful when you bring up the word internal brace. He gets way too excited. Every surgery I bring up, he wants to add it. So, but anyhow, that's amazing, right? Because to me, I had 6 people with ACL tears today in the office, and every one of them I was like, "That's the internal brace part's not the problem. Like that's been studied, you know." And so they're coming in, like 2 of them asked for the internal brace. And so to me, that you saying the internal brace part was the hard part at the beginning is super interesting, because that's just the difference now with the internet, right?
Yeah.
Like the last 2 weeks, I've had people with ChatGPT. They came to me, we talked about AI, and they're like, "Hey, my surgery, I need to have this." I'm like, "Who came up with that idea?" They're like, "Yeah, it's an internal brace. They want to have a quad." And I'm like, "Did you talk to the surgeon?" They're like, "No, ChatGPT told me what I needed." I'm like, "Oh, that's interesting." But anyhow, the fact that that's out there, right?
Yeah, Yeah, so, you know, I can remember in the early days, we were in Naples, and I ran into Dr. Pat Smith, who he was doing it with hamstrings and some canine research at the same time that I was using it as part of our Fertilized ACL, okay? And so we were simultaneously really doing the initial research on the internal brace. And there were so many questions about, does it cause synovitis? Does it work? Does it over-constrain the knee? You can talk about all those things. And now sitting here 8 years later, it's not controversial anymore. But like when you asked me the question, what was the hardest part of the selling the procedure or talking about the procedure, I would say I had a lot more questions and concerns about the internal brace than using the bone graft in the bone.
Interesting. Well, I see that part. I meant more like, I think we'll get into the recovery timeline. But yeah, I mean, selling the biologic idea, at least in my practice, has never been the challenge in terms of like, you know, everyone wants, like we talked about this to recovery shop. We talked about these other things, Will, like everybody wants the best, right? Like these patients are coming in, they want the best. And so, you know, Chad's got this sort of super innovative new technique. Like they're super interested, and he's got the trust locally. Like I know I grew up where I practice. So I have the same situation. I mean, I see people I went to school with, coached, you name it. Like those are the patients that are more willing to trust me and try something like this that's different. And I understand that, that's interesting that background was there for you. Do you know what? So can you explain? I want to go over this fertilized ACL in a second. Can you explain what the importance of dealing with the ACL was? Like, I can go in nauseum, but obviously you're the one here and you're the expert. Why did you choose the ACL? Like, well, why did you choose ACL reconstruction, and why did you choose something like this? What was the reasoning?
Man, rotator cuffs are a lot more easy for me in the OR. Like, I mean, you know, you can do a double row rotator cuff, and like, I can't tell you how many times I've said, man, I should have developed a new rotator cuff procedure. It takes 35 minutes, you know, but and the ACL, you know, an autograft ACL takes longer than that. But no, the reason is because, in my opinion, when you have a re-rupture of an ACL in a 17-year-old, that's almost like the end of their athletic career in most cases. Because you take an injury that was maybe 1 year and now you've made it at least 2 years long off the field, right? So in most cases, let's say you get hurt in August, you miss that football season, you come back in the spring, you re-tear, you miss a whole nother season. So my goal was, and here's how we got started with this process. A patient came in, for example, and did not want a staged reconstruction, okay? And so you start to think about ways that you can improve the healing process and the bone. And that's kind of how I came up with the idea of using bone graft in a primary setting. You understand what I mean? So instead of staging with bone graft and then going back in, I said, okay, wonder if this would work. And then once I did it once, I started saying, okay, let's just do this in all of our primaries to improve the healing process. And it made sense to me.
Yeah. So Will, that's to jump in we talked about this with Chubb. So basically you get these patients with big tunnels, and so you don't want to do another ACL on them. And so what he's saying is that he found this way to try to like, can I bone graft and do the ACL at the same time to skip that step?
Yeah, but the
And it's
inspiration was off the re-rupture, right? So after the
Right.
re-rupture, that was the inspiration. And then once you caught on to something that you're like, this is working, then that became your primary for any procedure that had to do with the ACL, not just a re-rupture, but the inspiration to kind of, be motivated about finding a solution, especially for these young adults that are losing 2+ years of their athletic career, came from this re-rupture, which is fascinating. So as we talk to other doctors and we hear about inspirations, is usually that inspiration to help someone, to help the patient have a better quality of life. So I always find that key when I hear these things and saying, this is what motivated me, this is what inspired me, was to find a solution.
And Chad, can you talk about the delay? What is the delay in the recovery of ACL, right? Like you talk about tunnel healing, right? So that is part of your process as well, I'm assuming.
Yeah, and I think the biggest reason I chose ACLs as my main interest of research and innovation is because of it goes back again to my upbringing and having friends that tore their ACL both in high school and college, and seeing what they went through to get back from that surgery. And my thought process was, okay, yeah, the patella tendon may be a great autograft, but is there another option that hurts less, possibly long term, hurts less earlier, and we can get patients back easier and maybe let their recovery be easier and more thorough? That was my whole thought process. Some of those questions we're actively still studying almost a decade later, guys. I mean, and when we get to the study, we can talk about that. But I mean, it's unbelievable how long it takes to find answers. I mean, real legit answers, not just we can do this. I think it works. It works in some people, right? Does it actually work?
And so can you describe, I know we have this really nice slide here, and I want to get to this and just kind of show this for the viewers, but can you describe your newest tech? Because obviously you've done some slight modifications and trying to make the perfect titration. You don't have to go through too crazy details, but people have seen this. I've already talked about the first slide. This is like the fourth time, but obviously the first time having someone like you, the expert that invented it, on. Can you tell the viewers kind of what you're doing right now to do a fertilized ACL so they understand the differences?
Yeah,
they think they do, but
man, that's an excellent point. That's a really excellent point, because early on, the first time that I published it, it was with a patella tendon graft, and I threaded an internal brace through the interference screw on the tibia. Long story short, I was using a patella tendon graft. Then I used amnion. I went through an amnion stage. And then I settled on the use of a quad tendon with the composite graft, the bone grafting in the tunnels, and an internal brace right next to the quad tendon. So I settled on the soft tissue graft with an internal brace and the composite grafting of both tunnels. And that period and that process probably took a year or two. And then we started actively looking at our results. And still to this day, now I'm looking back at some of the 6-year data that we have, and trying. I mean, we had a research meeting this evening before I came on here, and we're actively trying to find those that may be interested in looking up those results, calling patients still, finding patients, seeing how they're doing. And I mean, it's a labor of intense love, research is, I would say.
So, and then you're adding biologics. So what are you usually adding to this? Because for the listeners, you got the bone graft you take, which is, we can learn about that. But
in simple terms, what we're adding is we start the procedure and we take bone marrow aspiration from their shin bone. Okay. That liquid gets spun, and you can use PRP, or you could use BMC, which is bone marrow concentrate that has stromal cells. Don't really like to use the word stem cells. Okay. So stromal cells. So it has stromal cells within that BMC. So that's liquid. And we'll add that to a demineralized bone matrix that forms a putty. Okay. It's thicker and it forms a really almost solid putty that's a graft. And those two components really form our composite graft that we inject into the tunnels. So that's kind of how we come up with the slush puppy. People like to call it a slush puppy because it looks like a slush puppy.
Yes, and it coats the graft. So the idea is it coats the inside the tunnels for the listeners. And there's a gap right now. There's just nothing's there. It's unless you have a perfect tight squeeze, which you won't get the ACL through, you have to have a little bit of a gap. So now you're basically accelerating that hopeful healing process. So let's go to the clinical trial, and then maybe Chad can explain it to us, because this is sort of the big one.
Yeah. So this, let's go ahead and talk about this. So 2021 is your date here, and it didn't fully publish in Arthroscopy, the Journal of Arthroscopy, until late last year, 2024. So and we started before COVID. So we're talking about 2019. We started enrolling in this trial or earlier. And the reason is, so you enroll, 60 patients or 100 patients, you do their surgeries. Then after their surgeries, you have to wait 2 years to properly publish. It doesn't matter if you're looking at 6-month CT scans, 2-week results, 3-month hop test. It's not getting published until 2 years after that last patient.
Well, especially in the journal, you published it, right?
Yeah.
I mean, you went big.
Yeah, we went big, and there's always flaws that people will point to in any study. But in our study, it was randomized and it was controlled. It was a randomized controlled trial, 60 patients, and we used both autografts and allografts based on age. So it wasn't just a bunch of 18-year-old soccer players, right? We're looking at across all age ranges and made sure that all that was even, okay? And half the patients received the augmentation with the internal brace and the biologics. The other half didn't. And what we found is the half that had the bio-ACL, fertilized ACL, had improved function at just 12 weeks. As you see, 80%, they scored 80% on their hop testing, which is a measure of their function, compared to the opposite group, which was around 35%. And many of those patients didn't even perform the hop testing. So
yeah, that's pretty impressive at 12 weeks. That's just not common.
No, it's not. And so the bigger issue is we found that the tunnel widening was less. Okay. So radiographically, the bone incorporation was better, and there were no re-ruptures in either group. And every single subjective measurement that they filled out on their surveys throughout the study favored the group that was augmented. Only a couple were statistically significant, but they all favored the augmentation group. So based on this study, we put our heads together and we said, okay, how do we see if what's important now? So we did the randomized controlled trial. So we said, well, let's look at this in a larger population of athletes, and let's look at less than 25 years old. Okay. So currently right now at Marshall, what we're doing is we're doing a 125 patient prospective earlier return to play study. And what we're doing is we're seeing if that 3-month hop test is similar. And I think right now, if I pulled it up on my computer, it's 70%, 75. So very similar to that 80% at 3 months. We're testing MRIs at 6 months, and we're seeing on average less than or equal to 1 millimeter widening on the femur and the tibia, which is exactly what we found. And we're also seeing, we're not seeing poor results. Does that make sense? So not re-rupture, those types of things.
Well, this is great. So I don't want to cut you off. I want to make sure that you're doing a fantastic job presenting. I want to make sure the layman people can hear this, because these are the people coming in, like the orthopedic surgeons. Like, we read the fertilized ACL, we get it. Like I'm all on board. I love this. So the tunnel widening on the CT scan, for everybody listening, is like the concern with some of these soft tissue grafts is they have bigger tunnels. That's one issue. The second issue is the reason they can't get back faster is for many reasons, but one of them is because the ACL isn't healed to the wall fast enough. And so that's why people are scared to let people go back at 7, 8, 9, 10 months. So you basically showed that your way is getting the bone to heal faster and that they're stronger. So it's like the perfect trifecta, which is why you've shown some crazy videos of some people doing insane things at a much faster rate.
Yeah,
right?
those,
I mean, I know you're laughing,
those
but
didn't go over well.
videos.
Those didn't go over very well in the orthopedic community. So
I'm sure it didn't. I'm sure it didn't, but I loved it. So I mean, I remember seeing the first one like 3 years ago. I was like, "Is this real?" So it's pretty awesome.
I talked to somebody today. I don't know. They were maybe 6 or 8 weeks, and I said, so they were asking about an activity, and I was like, "Listen, if you do that, just don't tell me about it." You know what I mean? So I was like,
no, but I think the idea is that you feel a lot more confident with, I have those patients come in there 6 months. They're like, I'm still nervous. And you're like, no, listen, I know that this is stronger. I've done the tests on this, right? Like, just so the listeners know, you don't normally get a CT scan. You don't normally get an MRI at 6 months, right? No. That's a study-based thing. So you're doing every check, right? AJSM is going to be like, I don't trust this thing. It's totally out of here. And you need to make sure like this was literally sealed tight study. So they did everything possible, like anything negative that someone can think about, you already covered it. And so that's really important for the listeners.
So we did CTs and MRIs in our previous trial when we compared the groups. This trial, we're doing 6 months MRIs. And the reason is we can, it's less radiation on 125 patients. So that would have been hard to get through the IRB. So the MRIs can still tell us the tunnel widening, which, it's like I said, less than 1 millimeter at 6 months in both groups right now. And I think we're up to 70 patients.
Wow.
So the other thing that we're finding and we're looking at is I have an independent radiologist that's looking at the signal of the ACL graft. So I'm trying so some of what we do in research and what we're doing with this study, we're also doing HOP testing at 3 months, 4.5 months, and 6 months. And I'm doing virtual reality testing. So I hook them up to I have somebody that's their whole job is they take our ACL patients and they put sensors on them and they do Dorsey V testing and they do virtual reality testing on a screen like a PlayStation Move. It's not that, but it's similar. And then that gives them limb symmetry indices and things of that nature that we'll be able to go hopefully 4 years from now and say, okay, the patients that had issues or re-ruptures or didn't do well, when you look at their RSI scores and all these things, we'll go to try to correlate that with all that data that we're getting. So, we're trying to get a treasure trove, if you will, of data. And like I said, maybe we'll find that, the signal to noise ratio on an MRI of the ACL graft after this is improved, and that helps you with your re-rupture rate. I don't know, but like you're right, we want to look at every detail that we can and not just say, well, these patients scored better on a subjective measurement.
Yeah, and it matters too, right? Like the data is good, but you want to make sure you have everything covered, right? Like, because patients don't really know what their IKD score means or anything else. They're like, oh, that's great. They want to know, am I going to be stronger, faster? Am I going to get back longer? And is there higher? Am I going to rupture sooner if I go back earlier? Because, right, the whole thing we've ever been taught is that the sooner you go back, the sooner you re-rupture, right? You go back before 6 months, there's a concern, not in this case, but you know what I mean? Like there's been data about that. So that's a concern, which is why we never let people rip until 7, 8 months until we've had new data. I know you're laughing about it, but it's a big deal. I mean, that's patients.
I'll tell you a story. So Dr. Tim Hewett, who is a world expert in biomechanics after ACL reconstruction, he's the one that wrote all of the data that we have on preventative techniques for ACL, for female athletes and things. So a mutual acquaintance of ours, we're at a conference. We didn't know each other. He had just written a paper that said you need to wait 2 years to get back after an ACL or else, right? And so
this is going to go well.
Yeah. So they set us down at a lunch it was at a meeting in Nashville. And so we sat down and we started talking. We're across from each other, and he's hammering me about the technique and my thought process, and and I'm listening to him and his views on things, which he makes sense and he has data behind. and he's a world-class researcher. So rather than us getting into an argument, we end up realizing that, hey, the only way to really figure this out is to work together. So he comes to Marshall, and now we're working together on this research study, and he's studying the biomechanics. I'm studying, I'm doing the surgeries and the clinical scores and the MRIs, and we're putting our heads together to find out if and we're letting patients go back at 6 months, and then we're going to say, hey, is it smart or not? And let's figure this out. If they went back at 6 months, what was their re-rupture rate? And what's that compared to in other studies? And
we'll show that comparison up there.
Yeah.
So Chad, I mean, this is amazing, right? Will, he found the highest critic possible for his study and decided to make him his colleague. That's insanity.
Yeah, I love it.
Like, if your study works, I am all in. I already believe in this. But like, you did the worst possible research thing ever, and you found your biggest critic to do the work for you. So like, this is incredible. Like, listeners, like, you cannot fight this man. Like, he has done everything possible to try to destroy what he's doing, and he's still not doing it. So this is fantastic.
I think you don't want to, no matter what you're doing, you don't want to surround yourself with yes people. You want people in the room that are going to question everything you do, because if I get on a show like this, or if I get up on a podium, I want to have already answered those questions that you're going to ask me. I mean, it just makes sense, right? So he was able to come in and really look at help us design this study that we're doing now, which is it's called a early return to play study after fertilized ACL. And we're doing 125 patients. We're going to follow them for 2 years and then 5 years and all that. So
we'll pull that back up. Don't go away from that slide. I need him to look at that. I like this. So everyone thinks this is good because Chad's getting the heat here, but I'm about to get the heat in like a month when this publishes, and I'm going to get the heat in terms of like my own patients asking about this. So it's important that I show them all this stuff, because they're going to want to know it. Like, this podcast can be listened to, and I'm going to hear, you're on your podcast, you said this. And so it's important, like, right? Chad has his own thing. He's invented this fertilized ACL, but there's hundreds of thousands of doctors that are doing this. And they're going to see this, and they're going to say, hey, listen, tell me more about this. I want to know about this 6-month recovery. We're looking at it, the limb symmetry, the tunnel widening. But this comparison is really important, and people come to that. So again, 6 months is not crazy, right? We have our own patients that are non-traditional ACLs that are 6 months, 7 months. So this is not insane. And again, I think part of this is what your technique is, and part of it is probably you feel comfortable at 12 weeks with them doing the strengthening, the limb symmetry, right? Yeah, I would imagine it's kind of a combination of everything.
Let me explain our thought process there for a second.
Yes.
So when we went into the design process of the study, and I talked to Dr. Hewett, we were going to do like several different arms of the study and have some patients able, if they pass testing, to go back at 4.5 months. And I go to a couple conferences and I realize that, hey, people are still up there on stage talking about 9 months. And I talked to him. I said, listen, I've let every patient for 10 years go back at 6 months. Let's just show that that's safe. Let's get an actual re-rupture rate at 6 months with the internal brace and the biologics, and let's prove that part of it before we go crazy and try to reinvent the whole rehab process. You see, I think that's how we fell on a 6-month time frame. And the other thing I want to point out, if I can, is people and surgeons and patients sometimes take grains of what's out there and they say, oh, I'm going to get back like within 6 weeks or 12 weeks because these patients did well at 12 weeks. That's not what we're promoting. That's not what we've shown. We're showing improved results at 12 weeks, but in no case have I signed a letter of release at 12 weeks. Okay, so I think that's important to point out. I wait until the 6 months, even if they pass their HOP testing and are doing excellent, I wait until 6 months. So
it's important too that you're saying that, right? Because they all take this and they're like, well, that was me, but I'm not average, right? Like, I'm better than average. And so I'm a 4-monther. And what you're saying too is the shock factor, right? Like, the video I had seen showed the 4.5 month insane response. And
Yes.
so like you said, like even someone like myself that's all on board with this, I work with Arthroscopy, I do the biologics, I'm all into the innovative stuff. And I'm looking at this like, holy cow, right? Like it's not someone who's been indoctrinated for 20 years into the exact same surgery, right? It's a shock. So the 6 months to me, I'm like, I can handle that. Like I can easily tell my patients 3 more months, I'm going to cut your time in half. That sounds insane. Like that's the other thing too, is it almost seems like too good of a, I hate to say the word sales pitch, but locally, right? But you've got patients flying in for this surgery right now. And so the idea is that like, you want to be careful with your pitch too, because you are selling it. You're still selling the procedure to the patient. So making sure that it's sort of like the appropriate expectations. But this is awesome. I think it's really important that we brought that up. So thank you, Chad. I really appreciate it.
I do think we have a important aspect of protection for our patients, I mean, and because sometimes, and a lot of times patients will call from, I mean, we've had patients come from other countries to this small town in West Virginia. And I know they get here and they're like, what in the world? Is this the right idea? So, and sometimes they get lost to follow up. I mean, as much as we try to call, but anyways, I'll tell you that, that it's very important to make sure you carefully word what you're saying, especially in promotional activities. I've learned a lot about that. I mean, and we still do let patients, any videos that you see me repost generally are posted by the patient. Okay. So I don't really do a lot of posting of the videos anymore. Like most of our videos are patient driven posts because they're excited about their rehab, and and we want to support that, but we don't let them go out and play at 3 months. And I think that was a big misconception, that we were rushing people out there. And that was, let's talk about that for a second, because that was frustrating to me. Okay.
That's important. This is good.
Yeah, because we were putting so much work into the design of the technique, the design of the research, and following up on patients, and really closely I mean, I literally at times have sent people to high schools to make sure we get data on patients that were lost to follow up at certain time points. That's how much how passionate we are to get the research data,
Yeah.
And so it's frustrating when people would come back and say, you're out here telling people they're going to you're rushing them back to activity. And that's not true. That's a false narrative.
Did you hear that more from your peers more than anybody else? And not so much.
Yeah. Oh yeah. I mean, because what
I don't
happens,
know if I'd call it peers, but
I mean, what happens is somebody goes into his office and they say, well, Dr. Lavender over there at Marshall is letting people go back at three months. And that's just not true. And so when they call us, and they get to me, we have a protocol we do with out-of-state patients. When I do finally talk to them, I spend 20 minutes or more talking to them about expectations. Mm-hmm. Don't come here for surgery if you think you're going to be released at 3 months. That's not okay. And it happens this time of year, every year, because the football players want to get back before football season. Yep. It's just not going to happen. Okay. Now, maybe the end of the season, maybe if they're a high level player and they play in December or January or whatever, that's different. But it's just not going to happen in 3 months. And so very, very, I make sure that I'm very clear with them about expectation, and, come here if you believe in the procedure, if you believe in the science, or, if you trust us, but don't have that expectation that you're just going to be progressed at a rapid pace on purpose. I mean, every night it seems like I'm texting with patients about their rehab and things like that from out of town. And I mean, I think that's a very important part of the process, is making sure they have an understanding at each stage what they're allowed or not allowed to do.
It sounds like you've had a lot of support from Marshall. What has that experience been for you and for your peers there? Just kind of working at the facility, embracing the fact that you're doing something that's cutting edge, and embracing all that. What has that experience been, and how's that helped to get you where you're at now?
Really, it's the hospital system and Marshall both. I can't say enough about some of the residents that have been involved with me. I mean, we've had residents that have won awards and really put in, that study that got published, for example, I'm going to say his name, Andy Shaver, Dr. Shaver. He put in at least 50 hours of work after the study got really not denied, but accepted with revisions kind of stage. I mean, it was a ton of work on his part. And without people like that in your life and in your workplace and supporting you, man, you can't do this. I mean, it took me, we got the book finished in maybe 6 months, but it was every morning I was up, 5:30 or 6, because they're in a different country doing their revisions. So they would send it to me late at night, and then I'm up doing it before I go to work. That was the thing. That was different than a study, because you write a study once, you write that book chapter, it seemed like over and over and over. There was always a different edit. But yeah, back to your point, Marshall's been great. And I think, I'll say this, as you go through your career, it's very difficult because, you exponentially grow in volume, and it's very difficult to continue to grow with that volume. There's days we'll go to clinic and see 90 people, 80 people, and have patients for, have telehealth and all this stuff, and it's you have to add staff and kind of grow with that. And Marshall's been great about supporting this in all aspects, and it's really cool to look back on where we came from, and, and the area we're in. If you've never been here, you should come and see how small of an area it is. It's really remarkable that somewhere like this, people come to, but
it's amazing.
That's awesome. Well, I think that this is it's a perfect segue, but also for all listeners, we've talked about this. What does it take, right? Like, this is not like a guy woke up, orthopedic surgeon, he came up with the idea, he started doing this on people, and now like a week later, he's got results. This is hours and hours and hours of grind. This is years of discussion. And this is also understanding that like innovation is not easy. Like, there's nothing easy about what you had to do and the heat that you had to take. And like, it's all great now. We can talk about this. Like, we got pictures from AI. I got patients coming to ask about the fertilized ACL who are in Seattle, who have seen your stuff, right? Like, there's a lot of work to get here. Now you're at the top and you've done it, and it's really awesome. And I would just say that it's extremely impressive, but thank you for sharing your story, because I think people need to hear this, because again, this is the most important part. What's the background, right? The sexy stuff's great. Like, at the end, you got the marketing, you got Arthrex backing you, like all those things are amazing, but that is not, it is not easy. Right?
No,
and you did it.
I'd like to say something about that, because that's probably the most excellent point that anybody could ever make. Is research is hard. And when I got started with that study, as we mentioned, 6 years ago, I was 38 years old. And, I'm like a young guy then. And that thing finally gets published. A half a decade. And so they're like, well, what are you going to do now? And I said, I don't know. But it's probably my last study. I'm just going to be honest. If it takes almost a decade to do a book,
you can't do that pace, man.
I will say too, I want to point out that one interesting thing that you learn. So, our re-rupture rate right now has been about 3% compared to 10% that we've seen. So we have 3% re-rupture, over 10% contralateral tears in our patient population. Yeah. Okay. We haven't changed contralateral tears, which in my opinion points to two things: the validity of our research, but also the fact that contralateral tears are a separate subset and unrelated to how well the ACL is on that knee. I think it proves the patients are getting back to a high level of sport, and therefore they have a high level of contralateral tears. The other thing I wanted to point out is we found, I think it was 9 to 10% of a need for a manipulation and or release in our study, and it wasn't different between the two groups.
That's important.
And so, what I did? I said, what is different about my out-of-state patients? Because my out-of-state patients, man, they came in here and they're here for 2 weeks, and they come in inevitably at 2 weeks and they've got 120 degrees of motion. They've got quad raise. They're walking. I mean, the one guy, that went viral with a TikTok who was walking without crutches, like literally the same day of surgery. And I said, what's different about this patient population? Well, you can say several things. One of which is they're here solely focused on their ACL, and they've made a major commitment financially and time-wise to come here to have it.
100%.
So that's a separate population of folks. Or you could say they knew that I wouldn't let them out of West Virginia until they get their money. I don't know.
I think both points are true, but I would tell you my out-of-state patients in general have some of the most incredible results.
Yes.
Because it's like, I hate saying the word out-of-state, like professional athlete, but they're like, they got all the time in the world. Like, they're like, I'm taking off 2 weeks. I'm flying out there. I don't care what happened. I'm going to make this look good. And, the TikTok guy probably had a lot of motivation for it to look good. He's now exploded on there. He's like, I got a show over on my knee, right? Like, the social media aspect of it is also motivating them.
I think so. What the point I was going to make is, what I started doing is I said, well, maybe my local patients are not going through therapy as frequent. Okay. So I went old school and got as many CPM machines as I could possibly get. And we lease these to the patients now. And so we retrospectively looked, and I haven't published this. If anybody out there wants to publish it, a medical student or whatever, call me. I don't have time.
Reference Spark Stock Talks. Yeah, they know you gave.
I don't have time to write up every paper, but anyways, what we found was, that 10% went down to, I think, 2 out of the last 100 patients.
Wow. Yeah.
And so you could make a case, the reason CPMs went away is they didn't make long-term differences. Remember, we talked about 2-year data.
Yeah.
But man, for an athlete, getting that motion back and not having to have a manipulation is everything. And that 10% manipulation need is very similar to, I think, Zarageny's data after quads, with his, I think he presented, it was like 7 or 8%. So I think it's
the most common surgery I do for ACLs.
Yeah.
It's the most common second surgery by far. Yeah. And I this week, last couple of weeks, I spent half the patients are mine and half for somebody else's.
Yeah.
From an ACL surgery. So it's no doubt a problem. It's funny, my complex knees, my meniscus transplants, HTOs, they don't get stiff because I give them CPM right away. Cole and I learned that at Rush. Like, I'm super aggressive with the CPM. So my bigger surgeries actually get lysis adhesions less than my ACLs. It's because of what you're saying. Right? And I'm like, CPM's old school, right? And that's not the case.
You were talking about secondary procedures. I wanted to go ahead and tell you, I've had about 4 patients, 2 of which I think were in our trial, that had secondary meniscus tears, late, like a year or 2 out after they played a season. And they had major knee injuries, tear their meniscus, and I go in and they tore their internal brace, and the ACL looks great.
Yeah. I just had one of these.
Have that happened?
I just had one of these.
See, so we weren't crazy 8 years ago. I mean,
I literally just had one 2 weeks ago, meniscus tear, internal brace tore. Somehow I forgot to hit the video button because I wanted to show that off on social media because I was like, this is crazy. I've seen it before, but this was like very obvious. ACL perfect quad, just like you're talking about. Like, I wish it was a fertilized ACL. That would have been sicker, but it wasn't. But anyhow, it was pretty cool. Chad, I want to do your last part because if I don't, we have to get off at an hour because that social media does not like over an hour.
Gotcha.
So we got 10 minutes to talk about Nano. And if I keep going, we could talk to you for like 2
hours. We got like 5 minutes because we need to finish off with a little football.
So
we got to talk
to Chad. We are not interrupting. We're not trying to cut you off. You're just an amazing guest. But can we talk about the Nano really quick for you because I know you wanted to bring that up.
All right. Yes. So here's the Nano needle. This is live, and that's what it is. So you might want to go to the slides you have, and we can talk about it real quick.
So explain to the patients what's the difference. Like, why do Nano?
So the Nano needle is much, I think I sent a slide over, but the Nano needle is much smaller. There you go. It's 2.4 millimeters versus 5.9 or slightly smaller than on a regular sheath. So you can do it through a needle stick. Really, with it's so much less invasive. You're pushing less fluid into the joint, I was an early adopter to this back when it was called the nanoscope, which was it's bulkier. Now it's just a needle scope, and they're also getting ready to release, hopefully soon, the Nano Needle 2.0, which is going to improve resolution greatly. I've had the chance to look at these in the lab. So the old Nano, I've got video comparing the old Nano to the new Nano to a regular scope. And the new Nano that's coming out is very, very close. It's HD and it's close to a standard scope, and you're just using a needle. And so it's remarkably more vivid and gives you that great visualization that you need. And so what we're going to be able to do with that is you're going to be able to do secondary viewing. Like I wrote about this in the book years ago because I knew this was where this was headed. You can park that in a joint, say the shoulder, and it'll give you, and now with the new software, you'll be able to put picture in picture or side-by-side views and have a standard scope view with a nano needle or multiple nanos and be able to work almost hands-free, right? And so that's where I think it's going. But I think the Nano is outstanding. Also, so we just finished a randomized controlled trial with the Nano multi-center, showing that it had 56% less narcotic use in the first 24 hours.
Wow.
That's huge, right?
That's huge.
So,
That's huge.
This was just for standard knee scopes, partial meniscectomies. Dr. Argentar, who was in Washington, D.C., was the other site, and we randomized patients. I think we had 70 or 80 patients in that trial. We'll be publishing that sooner rather than later. I'm not waiting for 2 years on that one because we're just going to publish it. No, because the 2 and 6 week scores were better, and so that's all we're looking for, right? So I'm not waiting 2 years, so we'll get that out there. But we also did a retrospective review and showed the same. So I can tell you with certainty that the Nano gives you very similar to better scores and less pain, less narcotic use, which I think we're all trying to decrease the amount of narcotic need after any surgery, right? So 100%. I think that has long lasting. That's why I wanted to bring that up, because I think the Nano has long lasting ramifications.
Well, and the thought process, Will, is asking what's next, right? Mm-hmm. Smaller scopes, tighter spaces, and multiple views, right? Like, what's going to make me more so? You have the nanoscope, right? Newer technology, maybe a little higher cost with newer technology, but like it comes at a price, right? Faster OR time. Can you get two so you're not having someone hold the scope, moving it around? You're trying to play the game like sideways, upside down. What are they looking? Right now, you got multiple views, and can you do your surgery more efficiently? Right? You said a 35-minute rotator cuff. Can you do it in 20 because you're not spending so much time transferring portals?
Yeah, and safer. So I'll put it in the back of the knee when I'm doing a PCL.
Yes, this is huge.
It's direct visualization, so I can tell a patient I'm going to be watching while we're drilling your tunnel right next to the vessel. So we put all those techniques in the book years ago, and now I think people are actually going to start adopting them when the visualization becomes HD. But it's been fun, man. I've had a lot of fun doing these innovative techniques and learning. And I will say to any younger surgeons out there or residents, research makes you learn and question more each day. You find answers, but for every answer you find, it seems like you ask 10 more questions. So,
well, and I would also say what's interesting is you went from a small town, team doctor, now Marshall. People are flying in for your surgery, right? You've now had this sort of fame of your innovation, and that adds another layer too, right? It's like you did all this work, and all of a sudden now you get on a podium for Arthrex or for some other company, and you're up there and you're talking. Now you got 1,000 surgeons, and the first time you're bringing this up, it's no joke, right? It's no longer you're just in this small little facility or small area talking. Like this, people are listening, right? Yeah. You're on this podcast, you're on other podcasts, like you've got a presence, so you've also got to back it up too. You've had a lot of practice.
It's been a lot of fun. I can remember when we had an article one day. Life has a way of just completely, I will say this, completely humbling you. But I can remember one day the Sporting News article hit, and I knew it was coming out sometime soon, and I thought, man, this is going to be awesome. And then it hits, and like, my day was the same as every other day of my life. You know what I mean? And it was just like, okay, on to the next day. What's the next? But it's taken us all over the country. I mean, I've been all over the country doing education and talks, and really I've met some fascinating people across this country, surgeons, patients, really talented individuals across all, like from all walks of life. It's really remarkable. And so, yeah, I think that there's that small town appeal of the story. But it's been a lot of fun. And I think, I will always say, keep the main thing, and that's patient care. And that's what we're trying to improve, the patient experience and their outcome.
100%. Well, Chad, this has been awesome. I know Will has some. Will, you're
no, we're just gonna wrap it up.
Go. You have a few minutes, Will, only.
No, we're just gonna wrap it up. Once again, Dr. Lavender, thank you for taking so much time. I know you're excited. You brought back Coach Rich Rodriguez. Are you excited about your Mountaineer?
Woo! We got a
woo!
It's really
excited there. What's going on with that?
I played for Rich Rod. And then also Marshall's new coach, Tony Gibson, was on that staff. So both coaches in state, I played for at WVU, and I was down. My son, he's 9, and he was down at Gibson's camp, and I got to talk to him, and I was saying, man, life comes full circle.
That's amazing.
Here you are here, and but what was funny is he told me, he said, I never dreamed my first day here at Marshall, I get called about somebody wanting to get in to see you for an ACL. so he told me that.
Dude, you are doing the hometown awesomeness. That is so fun.
That is great, man. We're getting excited about that football season here.
Yeah, we're excited at Marshall and WVU, with 2 new coaches. So we're excited with both of them. So
you got your tickets? You're gonna go?
Oh yeah.
Okay, I knew that. Dr. Lavender, thank you so much for your time. We really appreciate it. This was absolutely wonderful. I felt like we have so many other things to chat about, and I mean, we can go on and on.
The good guests like you, we could go forever. This is like, we're gonna have a 24-hour show sometime at this rate. These guys are so fun. And
I think the great thing is, I don't know how many years ago we were on together, but we have a lot more to talk about this time. So that's a good thing, right, guys?
Always.
It is a good thing. You're doing good work. So thank you, Chad. I really appreciate it.
Thank you, guys.
Chad Lavender. Thank you so much. Thank you for your time. Dr. Garcia, say goodbye.
Bye-bye. Thank you.
Bye.